I'll try to make this one as interesting as possible. So fluids is something that in the last five years, really, our knowledge has really advanced. Maybe even 10 years, but we're the veterinary profession, I think we were a little bit slower. Well, actually, no, I take that back. I feel we've been ahead of the human profession in some areas. Humans, they use a lot of saline, and they didn't use as much balanced crystalloids, whereas the veterinary profession, we were using Hartmann's or lactated ringers a lot sooner than the human profession. There's been some new advances, which I'll get into, about the glycocalyx, which really helped us understand the fluid therapy in the body, and when we give fluid, where does it end up? So the session overview, I'm going to go through some physiology, which is a bit heavy this late in the evening. We're not long until we can get the whiskies and the vodka into us. Starling's forces, the traditional view, and then I'm going to go through the glycocalyx. Who's heard of the glycocalyx? Yeah, a couple of hands. Good, awesome. Then we'll go through assessing fluid deficits and the difference between hypovolemia and assessing perfusion versus hydration, and using those parameters to assess your dehydration or hypovolemia. Then we'll finish up with choosing which fluid are you going to use and how to do a fluid plan, and pull it all together at the end with a case. So key concepts today, I really want you to take home that fluids are drugs. They're not benign. You used to, you think you'd hook them up and support them with some fluids and do a bit of set and forget. We actually can be doing harm, so you've got to be very intentional about what you're doing with fluids. In the beginning of my career, I'm sure I've had patients not survive because of my fluid therapy. You want to restore an effective circulating volume, not just any volume. So we really need to tailor that to the patient and not just picking a number that we want to give them. Maintaining cellular homeostasis, so that means you want to resuscitate appropriately, but not over-resuscitate. And avoid unnecessary volume expansion. Fluid overload kills. And in human studies, there's big studies showing that being in a positive fluid balance, you have a higher mortality. You reassess and adjust accordingly. Just because you do a fluid plan and do some fancy calculations doesn't mean that's actually what the patient needs. You won't know until you've started, and keep reassessing. So back to a little bit of the basics of fluid compartments. So our total body weight, 60% of us is water content. Of that, 40% is intracellular fluid, and 20% is extracellular of that 60%. So you're kind of chunking it out as you come along. Of the extracellular fluid, three-quarters of it is interstitial, and only a quarter of it is your intervascular. So that's a really, when we get right over to this side over here, which I don't think the pointer, it's a bit slow to go. This is our intravascular volume here, this plasma, 5%. Then we've got our interstitial at 15. That makes up your extracellular fluid there at 20% here. And then you've got your that's your extracellular, then you've got your fluid inside your cells, is this 40%. So when you're thinking about fluids, you really want to think about which compartment needs the fluid. What fluid am I giving, and where do I want it to end up? We're now rethinking about how a fluid moves across the vessels. We used to think of the traditional Starling's forces, where we'd think hydrostatic pressure pushes fluid out and oncotic pressure pulls it back across. So your proteins and how high your albumin is that going to be bringing it back across? The thought that we would give synthetic colloids, heterstarches, and be able to pull fluid back is all now being disproven, and our whole concept for many, many years, we were wrong. What we now understand is the vessel wall has a protective surface and this is called the glycocalyx that regulates fluid exchange. If this layer is injured, fluid and proteins leak and we get edema. The clinical impact is that more fluids doesn't mean better perfusion. Our aim is to really preserve that glycocalyx during the treatment of the underlying diseases and also in our fluid therapy. And this is it. It's almost like magic. It looks like it's fine micro, almost like a little hairy lining on the inside of blood vessels. Microscopic, like it's so small. So you've got the vascular lumen here. Oh, I've got slow. See if I can get this working. Oh, no, maybe I'll just try it down here and see if this is going to work. It may not. No. Inside the white circle there, you've got that's your vascular lumen, and then you've got that blood vessel end on and your glycocalyx, whereas this we've got it side on here, and you can see the glycocalyx there. I'm trying to describe it really simply because when I first learnt about it and I read these high-end articles, I must admit my head got in a bit of a muddle. I was like, what's it actually doing? You kind of think of it as this really fuzzy layer that's almost like a soft Teflon coating. It keeps blood flowing very well. It's constantly sensing as well. It'll sense the differences in shear stress and adjust the vascular tone. And it's got all these little tight junctions preventing fluid and protein leaking. When the glycocalyx gets damaged, and it can be damaged by a lot of different underlying disease processes, or shock alone damages it, sepsis, trauma, burns, if you've got high blood glucose, giving rapid crystalloid boluses, getting them fluid overloaded, or giving heterstarches, makes those all, it shreds, all those little fine hairs kind of disintegrate almost and end up, into circulation and gone. Almost as quickly as we can damage it, it can rebuild, but it can rebuild over hours, which is amazing. So the barrier breaks down, we get fluid and protein leaking, and we get tissue edema. There's loss of flow sensing, poor vascular tone, and you get vasodilation. And perfusion may get worse even when vessels appear full because everything is leaking. So we want to protect our glycocalyx in all of our treatment and even how we give our fluids. That's why we're a lot more smaller appropriate boluses and reassessing. And if we can avoid fast bolusing, they've found that that can damage the glycocalyx as well. So instead of giving a bolus over 5 minutes, if the patient's stable, I may give it over 15 minutes and just slow it down slightly. The indication for blood products sooner to protect the glycocalyx, so low levels of albumin in your FP or FFP. So giving plasma is actually glycocalyx protective because that low level of albumin sits and helps the protein levels in the glycocalyx and has been shown to help heal it. So fluid status, when we're going to go assess a patient and go, right, should we be giving this patient more fluids or not? The two ways I think of it is I think of, right, am I giving fluids for perfusion or hydration? Perfusion equals blood flow, and it's the movement of vessels through movement of blood through your vessels to deliver your oxygen to the cells, and then you're taking your waste products away, your carbon dioxide, and all of your waste products of metabolism. Your perfusion is determined by your intravascular volume, your cardiac output, and how tight your vessels are, which can rapidly change. This can change in minutes when you've got a patient that's critical. So this is why rechecking those perfusion parameters, those 6 things you're going to check all the time, really help you assess your perfusion. Versus your hydration, I think of this as your extracellular tissue water balance, and the main one is it's your interstitial that we're really looking at. So there is a little bit of the intracellular, but on a physical exam, you can't really tell how hydrated the intracellular cells are. It's more that interstitial that you're looking at when you do skin tenting with mucous membrane, how tacky they are. These changes occur over hours to days, and you're going to assess it by assessing how elastic that interstitial layer is. So this is the layer, this is the area that we're looking at where we're assessing hydration. A key concept is a patient can be dehydrated but still quite well perfused. You know, they may not have changes in their perfusion parameters of their heart rate, their mentation, all those signs of shocks I keep going through and we'll go through again. Or they can be hypovolemic but still clinically hydrated. So they don't, you can have one or the other. Sometimes you have both and you need to address both. I try and think about it as perfusion is blood flow and hydration is that extracellular water content. How to tell them apart? Again, trying to keep it simple. I feel like I do repeat myself a little bit with these perfusion parameters, but the perfusion is dynamic and it's changing over minutes to hours. And we really want to maintain, when we're maintaining perfusion, we're maintaining our oxygenation at the tissue level. And these are the 6 perfusion parameters that hopefully we've all remembered now, is your mucous membrane color, your refill, your pulse quality, your heart rate, mentation, how aware they are or not, and whether their extremities feel cool. If you've got deficits in those, they're going to be hypovolemic. If you've got hydration, so it's slower to change, it's maintaining the cellular environment, and it's assessed by mucous membrane moisture, how tacky they are, whether they're skin tenting, their eyes are sunken, their body weight percentage changing. If their saliva tear film is dry, which can be a bit hard to tell sometimes, and sometimes a dog that's been panting will have quite a dry mouth. But if we've got deficits in these, we've got dehydration. So when we go through these 6, this is what we're looking for. If they're pale, if they've got prolonged CIT, if they're tachycardic, so a normal heart rate will vary. Large breed dogs, 60 to 80 is normal. A smaller breed dog, 120 and above. So I kind of take that with a grain of salt as to how big the dog is. I'm feeling for my pulses. Are they weak? Are they thready or absent? And is their mentation dull or obtunded or peripheries cool? So this is just a really good physical exam. Whereas hydration, again, mucous membrane, skin, eye, body weight, saliva. We often do it over the scruff. I couldn't not put this photo in and had online of showing that over the head. Dehydration is they're tacky to dry. Sometimes it's just tacky all the way through to dry, and there's variation on both of assessing your hydration and your perfusion on severity. Eyes are sunken, decrease in body weight. Sometimes their saliva goes all thick, dry and stringy. Sometimes they've just got a dry tongue. Dry nose is another one. Again, good physical exam. Estimating percentage dehydrated, we use, and this is only an estimate, we're never 100%, and that's why all of your fluid plans, you get a starting point from your estimate and then you assess the response. Generally less than 5% dehydrated, you're not going to notice much difference in your physical exam, sometimes really slightly tacky gums. Whereas once you're heading 5 to 6, you are starting to see definitive signs. You've got to be careful if they're really old. Sometimes their skin elasticity isn't as good and you will get skin tenting, or if they're really skinny. And if they're really fat, it jumps back down very quickly and can seem like they're a bit overhydrated, but there's actually just a layer of fat under there. The further through you go and the percentage dehydration that you get, the more marked your skin tenting is, the drier your mucous membranes. Once you're 10 to 12%, you actually can start drawing from your intravascular space, and you can start getting signs of hypovolemia as well, just purely in how dehydrated those patients are. So if they've got nothing else going on causing the hypovolemia in combination, dehydration alone can cause hypovolemia. So when we've got our different types of fluids, you think of them of like, what are they going to do when I add them to the body? As I try and think simply. A hypertonic fluid has got higher salt than, go back one, it's got higher salt content than the blood. So when you add it, you've got higher sodium. It's going to want to take free water from anywhere, mostly intracellular. And you think of it, right, my blood cells are cells. So it rapidly takes extra water from those cells. And that's how you get that effect in hypertonic saline, where you'll briefly get an increase in intravascular volume, which decreases your viscosity, which is quite nice for head traumas, and it moves through the vessels quicker. But it makes cells shrink. So, giving neat hypertonic, we do that briefly in certain indications, and it's normally your high sodium fluids versus, right, we're trying to correct different sodium abnormalities, which I'll go through at the end, of the indications to use hypertonic. The most commonly used fluids are our isotonic, so they've kind of got a similar sodium to the body. Hartmann's, Plasmolite 148, saline, they've all got varying degrees of their sodiums and different electrolytes in them, but the cells aim to stay pretty much the same. Initially, 5% dextrose, which is what we call free water, or DW5, it's dextrose in with water. The dextrose, the osmolarity of the dextrose actually makes it similar. It kind of goes into the body, and the body initially thinks it's isotonic, but then you metabolize the glucose, and the body's left with free water. So it's a safe way of giving a hypotonic fluid, really, because the body takes on that glucose. So when we're correcting hypernatremias and using free water, we're using dextrose and 5%, knowing that that glucose will get metabolized. Versus a true hypotonic, so half-strength saline, or just free water with nothing in it. But if you're going to give just free water with no dextrose, you'll get problems. You'll get you'll get your cells swelling, and you'll get hemolysis of your red cells. So the other thing to think about is the osmolarity of the fluids, which is kind of to do with how much salt. So I guess, hypertonic, high salt, and those hypertonic fluids have high osmolarity versus the hypo ones. This diagram I probably just put in more for completeness for your notes to go through. There's a lot of information online about different fluids. You can actually get diagrams of what electrolytes are in each of them. What fluid, out of interest, who most commonly has Hartmann's or lactated ringers? Yep. Saline. Is saline a common one? Does anyone have Plasmolite 148 or 56? No, so Plasmolite 148 is got magnesium in it. We use it quite a lot in quite our critical patients or in our DKAs, but probably the mainstay would be Hartmann's or saline. You've got to think, where does the fluid end up? Is it going to end up staying in your intravascular space, or is it going to leak out and sit in that interstitial space? And to be honest, isotonic crystalloids, only a quarter of them stay where we first put them, which is in the intravascular space. And that's how we get these horribly edematous patients. And when we see them with that peripheral edema, hock edema, face edema, all around, everywhere, it's not just their skin, all of their organs are as edematous. So you think on the inside, here you are, got the surgeon doing these amazing foreign body surgeries and resecting and doing intestinal surgery. We go and fluid overload them into post-op care. That's a much higher chance of dehiscence from fluid overload, because you get that surgery site all edematous. So be very mindful that you don't just chase these patients with continued crystalloids. If you want it to stay in the intravascular space, you're going to give blood products. So blood or plasma will actually stay where you put it versus crystalloids. And free water is even free water goes across all your cellular spaces, with even less staying in your intravascular space. When they say maintenance fluid, that means plasma 56, which is like a low sodium fluid, or half-strength saline, because these isotonic fluids with the sodium as they're similar to the body, they're actually resuscitation fluids. So generally, if we keep patients on them longer term in hospital, and especially if they don't have access to free water, they'll get hypernatremic. My other key point is, if you've ever got a patient in hospital, they should really always have free access to water. Putting patients on drips, and we start messing with their sodium levels, and if you don't let them drink water, they can get very hypernatremic. Or if a patient is underlying is a PUPD at home and drinking a lot, weeing a lot, we take them and put them on a drip thinking we're giving them what they need, but they actually were drinking 3 times the amount of what we're giving, and we're giving them a salty fluid. Water has no salt. So if you're at home, they're normally just drinking free water, we go and put them on a resuscitation fluid, and we can end up with patients with iatrogenically, we make their sodium go through the roof. So I think be very mindful and don't just give it blindly, because it ends up where you don't want it. So the concept for fluids is replace what's missing. So if they're bleeding, and now that you hopefully all feel confident during blood transfusions, they need blood back. There's a degree where we can resuscitate those bleeding patients a little bit with fluids. Sometimes they haven't bled enough that we actually definitively need to give them blood, and some crystalloids are going to help them. But often if they're actively bleeding, we resuscitate with blood products. If they've lost plasma through different underlying GI diseases, sometimes those severe hemorrhagic gastroenteritises, they lose a huge amount of proteins and their albumin bottoms out. Plasma is indicated. We'll give them back on those CRIs of FFP over a day or so. If they're losing free water, we want to give free water back. We want to give low sodium fluids back. If they're clinically dehydrated, we want to rehydrate with a fluid similar sodium to their level. So long and the short of it is, if they're bleeding, we give blood, not masses of crystalloids. You focus on your perfusion endpoints and not reaching a set volume. And we're going to use our fluids quite deliberately. And you have every bolus you're giving, we're going to give it and then recheck them. Gone are the days of really dialing up, like I've said before, the shock rate fluids and walking off. I'm very much of the approach of give a little, reassess, give a little more, reassess, give a little more, and I might do that 3 or 4 times until I'm happy. Again, this is more for your notes, just a quick guide, right? What's happening? And what should I be replacing it with? And what is my aim in giving that product? So if they're actively bleeding, we need blood. Poor perfusion and they're not actively bleeding, so they're in shock, I'm going to give them isotonic crystalloids within those small boluses. In head trauma, it may be hypertonic saline or mannitol. Chronic dehydration, again, crystalloids. You can kind of see isotonic crystalloids, a more common one that we're giving. If they've got high sodium, we want to dilute that out. Or if they've got a free water deficit, we're going to give hypotonic, so low sodium fluids back to them. Versus GI losses, are they hypokalemic as well? And you can lose, are they losing their potassium, or got chronic kidney disease, and we may need to supplement with potassium as well, which I'll step you through at the end. So there's 4 aspects to your fluid plan. You want to correct that hypovolemia first, and this is kind of separate to everything else. It's done in those small boluses, which I'll go through, and I've got a detailed slide. Then you want to rehydrate them. So you calculate your deficit, the percentage dehydration, and we're going to give it over X hours. Each patient can be slightly different, and also the different circumstances. Do I have a surgeon breathing down my neck saying I want to take this really dehydrated patient to surgery because of its foreign body? And I might correct some of the deficit quicker. Versus I've got I may do it over 6 to 12 hours versus over 4 hours of that rehydration. You're going to figure out what your maintenance is, and then as the patient have vomiting, diarrhea that's going to continue, they're going to be losing more than actually what their maintenance was. So we'll put those steps in, and that's how you make your fluid plan. So step 1 is resuscitate. Step 2 is you calculate all three. So you calculate your maintenance, your existing deficit, and ongoing losses, and you add them all together. Again, there's different formulas for calculating the fluid deficit for if your percentage dehydration. So you'll take that and divide it by 100, times it by their body weight in kilos, and times it by 1,000. If you do some maths and just knock out some of your zeros there, you actually end up with a formula which is the same thing. It's the percentage dehydration times their weight times 10. So that's the easy one to remember. You figure out what maintenance is, and again, there's a fair few different formulas for figuring out maintenance. It can be your body weight times your maintenance of 60 mils per kilo per day is kind of physiological maintenance. So made that simpler by dividing, how much per hour. It's actually 2.5 mils per kilo per hour. You'll have we've got our feline specialists who will say we like 2.2 mils per kilo per hour in cats, all the way through to 3 mils per kilo per hour. I just take an average of 2.5 if I'm doing quick maths, because I know this is just a starting point. The most accurate is actually doing the body weight to the power of 3/4, but getting your phone to go into that mode, and I don't commonly use that formula. So you're going to correct your hypovolemia, you're going to reassess your patient. You already know how the percentage dehydration is different to your hypovolemic status. And you're going to correct that by adding figure out what your deficit is, add it to your maintenance, which is your 2.5 mils per kilo, and add it to your ongoing losses, which I'll average out. And that's a guesstimate. You think, how many times have they been vomiting, or how much diarrhea have they got coming out of them? Are they going to say lose an extra litre? How big are they? They're going to know you lose another litre in this next 24 hours, and then I'll divide that litre by 24. So when you're addressing hypovolemia, which I know this talk's come a little bit later in the sessions, I've already talked quite a lot about that. It's small boluses that you keep rechecking. So dogs, I go 10 mils per kilo. Cats, I go 5. And you do those 6 perfusion parameters just so often. I keep checking them. If they've improved after 1 or 2 fluid boluses, I'll cautionally transition to go, right, I'm going to put them on a more continuous rate of fluids rather than sitting there continually bolusing. If they're not improving after a few boluses, I think, right, what else is going on? Are they they got a bleed that I don't know about yet? So you kind of give a bolus, they get a bit pinker, their heart rate comes down a bit, and you think, oh, we're winning here. Then slowly that heart rate goes back up again and they go pale again. That's often a clinical sign that you've got uncontrolled bleeding. Have I got underlying myocardial dysfunction and cardiac dysfunction? Are they a DCM patient? Have they got underlying heart disease that they're not responding appropriately to fluids? Are they septic and they're vasodilated? So we've got a bigger kind of cup to fill, I guess. So you give fluids and you feel like you're getting nowhere because they've got no vascular tone. So if you've got hemorrhage, are we going to find that hemorrhage? You're going to go looking if you've got your ultrasound in the abdomen or the chest, and you're going to give blood products. If they're septic, and we've given a reasonable amount of crystalloids, 30 mils per kilo, and we've had no real improvement in their perfusion parameters or blood pressure, I might put them on a vasopressor sooner, so dopamine or noradrenaline, sooner than I won't just continue giving fluids. If they're in septic shock, and we've started with a vasopressor, so we've given an appropriate amount of fluids, the surviving sepsis guidelines recommend up to 30 mils per kilo. Dogs aren't small humans, but that's our guide. It's a key thing I find with the surviving sepsis guidelines in humans that have come out over the last 5 to 10 years, where they've really protocolized sepsis treatment a lot more, is the mainstay is just don't go giving masses of fluid. Give some boluses, and then go to vasopressors sooner than continuing on crystalloids. So if we've done that and I've given some fluids, I've put them on a vasopressor and they're still hypotensive and in shock, I may actually reach physiological dose of hydrocortisone. So this is a very low dose of hydrocortisone. Often it's like 0.5 milligram per kilogram per hour. And then generally that's the starting rate, and then you turn down from there over coming days. If they've got underlying cardiac disease or DCM, are we considering inotropes? And those heart patients, when they actually are really sick and need fluids, it's a balancing act. Normally, if you treat the underlying disease and we can always give them some furosemide if we end up with them in pulmonary edema. But our cardiologists will often, even though they want to protect the heart, sometimes we need to give these cardiac patients fluids. But once your perfusion is restored, you're going to return to maintenance rates and you're going to monitor your trends. So fluids are drugs, titrate to effect, and don't set and forget. The one caveat I have for you, but is if you've got a bleeding patient, we're going to try and keep them more on the hypotensive side. I've mentioned this before. You're going to be a bit more cautious. You're not going to go in with masses of fluid boluses until we've got that bleeding spleen, we've got the bleeding under control. They found this out, again, in war patients, where they started giving patients who'd been shot a lot of fluids, and they were actually dying and having poorer outcomes than the patients who weren't getting fluids before they got definitive bleeding control. So you want permissive, we want to just get their blood pressure acceptable, just feeling, if you can, palpating pulses. If you've got dorsal pedal pulses, you've normally got a mean of about 60. So just feeling pulses, we want to kind of be minimal amounts to get them to have still we want an acceptable circulating volume and perfusion, but we don't want to have any clots, as I don't know how technical dislodging clots with fluids is, but they get diluted out, so all their clotting factors are diluted. An increase in blood pressure, if you still had an area that was starting to clot, and then suddenly we have a higher perfusion of that area, you're going to not have clotting there. So aggressive fluids we avoid, sort bleeding control until you've got, once we've got bleeding control, we can give those fluids or blood products a little bit more aggressively. So you want to give enough, but not too much. Deresuscitation is something that is quite, big in the human field. They're very quick to stop you on IV fluids and switch you to oral fluids. Our patients, I feel we could probably do better. Once they're eating and drinking, they probably don't need a drip, and I'm a lot more mindful to not just keep patients on fluids because they started on fluids and multiple days in, they've been eating and drinking, and we've still got them on this salty drip that they don't need. Monitor their weight and urine output. So if we're starting to get really high urine outputs and they're gaining body weight in hospital, are we getting them overhydrated? Sometimes in our septic patients or hypovolemic patients, their renin-angiotensin-aldosterone system has massively been stimulated and their body is saying, hold on to more fluid. Then once we get them resuscitated, they doesn't quite switch off in time and they keep holding on to fluid. They get low urine outputs and they're edematous. You're not going to go chasing them with more fluid to try and get them producing urine. Sometimes all they need is half a mg per kg of furosemide to get them producing urine and shifting fluid. And so we often see this in our patients that have turned up in extreme shock. The emergency team have fluid bolused and resuscitated to get to, they've gone on to go to surgery. And by the time they're coming out 12 or 24 hours later in ICU, they're actually clinically getting overhydrated. I may actually cut right back on their fluids and give them a tiny bit of diuretic. So we'll go through some electrolytes, and again, it's end of the evening, I know the alcohol's calling. Electrolytes in itself is a whole talk, so I'm just going to touch on it. There's some great resources out there on sodium correction. Sodium is something that will mess with your head when you're thinking about correcting it. As you keep learning it, the more you do it, and every time you get a sodium abnormality in your patients, I'd recommend going and sitting down and reading a good sodium article so you know you're understanding it as you're correcting it. So high sodium, you think, right, we've got a high sodium, we've got free water loss, or we've got increase in like the little salt patient and ingested salt. So we're generally correcting with free water. Those salt toxicity patients that have ingested salt, sometimes there's actually an indication to get them to pee the salt out. We may use a diuretic as well. The crux of low sodium is that we've got a water excess or sodium loss. And are we going to either replace sodium with a higher sodium fluid or encourage them to pee that water out? So you're going to sometimes look and treat underlying causes, and being aware of what your antidiuretic hormone, so your ADH, is doing as well is something. Sodium can get quite confusing, but as I said, there's some really good resources out there. You don't want to change your sodium too quickly, unless if it's raised quickly, so if it's chronically changed and this patient has been presented with a chronic hyponatremia, you're going to bring it down very slowly. There's formulas on how to bring it down slowly and calculate different changes, which I don't have time to go into tonight. But if it's acutely gone up with a salt toxicity or an accidental, we've had in Australia, we've had a fluid shortage and they actually changed the labelling. We changed supplier. We got a hypertonic saline in from a different supplier. It looked identical to normal saline, and we've had some accidental overdoses across our clinics. They've gone on hypertonic saline and been resuscitated on that, and they've rapidly gone up, and we've been rapidly brought them down with free water. Potassium is something, if you've got vomiting or diuresis, so GI losses or diuresis, you want to supplement a low potassium. You can take your potassium. We have the vials of 20 millimoles or 20 milliequivalents potassium chloride. You can add 1 or 2 vials to a litre of fluids and give that at maintenance or twice maintenance is a cheap way of correcting potassium. Sometimes if we've got really low potassium, we're giving it higher. In ICU, because I like to have control of this rate, we often put our potassium as a CRI and separately, but I'm just mindful that we don't have lots of different fluid pumps and options, so you can definitely just mix it in with your main fluids. Don't bolus this fluid and don't let it run in free, flat chat. You can make them arrest. You'll kill the patient with this. If you've got really high potassium, you're going to give calcium initially to stabilize your resting membrane potential while you're buying yourself time to drive the potassium intracellularly. And you might be doing that with insulin and glucose to shift it intracellularly, say in a blocked cat. Also unblocking them in that blocked cat and diluting the potassium out by actually giving fluids, giving crystalloids. We'll quickly touch on glucose. So if you've got a hypoglycemic puppy or dog, you're going to give a glucose bolus. I've got a typo there, but a bolus, if you get 50% glucose in a bag, so strong glucose, my sheet that's in my head is 1 ml per kilo is going to be enough to kind of get me out of trouble. I may need to repeat it, but I dilute it out before I give it. If you want to make up a CRI of glucose, this is another cheat. Again, this is our whole team. We all do it the same way. You take a litre of fluids, you take 50 mils out from the bag, and you put 50 mils in of 50%. That gives you a CRI of 2.5%. So if you've got a septic patient with low glucose, sometimes 2.5% is enough. Sometimes if they're severely hypoglycemic, they need to stay on a higher glucose fluid. And I want my fluid to be an isotonic resuscitation fluid, and I'm going to make my own CRI of 5%, because otherwise the other 5% you can go and get is free water or half-strength saline, which I don't, often we want them on Hartmann's. So you take 100 mils out and replace 100 mils with 50% glucose, will give you 5%. We'll go through a case. We've got Shadow. He's a 5-year-old, 25-kilo Labrador. Actually my dad's dog. He has small intestinal obstruction. He's been vomiting for 2 days. He's really tacky on his gums. He's got severe skin tenting. We've done a blood test on him. His PCV's hemoconcentrated with a high protein, and we've estimated him at 10% dehydrated. The surgeon's hovering, he wants to go home and have a drink. He really wants to get into theatre. It's mid-afternoon. We're going to really try and get this patient a bit more stable and do a resuscitation plan where we're going to correct the first half of our deficit, maybe over 4 hours, and then we're going to figure out our rate for the next 24. So we'll quickly do a bit of maths together. I'm going to assess him if he's hypovolemic, and I'm going to give those boluses, and they're separate to my calculation. I don't consider them in my calculating my fluid plan. I want to give half my deficit in 4 hours. I'm going to figure out what his maintenance is, and I'm going to estimate any ongoing losses. So right, we kind of say the deficit, remember our formula, it was 10 times his body weight, so he's 10% dehydrated, times his body weight, times 10. So he's got a deficit of 2.5 litres for a 25-kilo dog. So that's quite a lot of fluid. Often when we put them just on rates, we underestimate how much fluid these patients need. Figure out, right, over 4 hours, we're going to give, we need to give him at a mils per hour. If I want to give half of that, that's 312 mils per hour. My maintenance, I've just estimated, get on the mid-range formula, 2.5 mils per kilo per hour. So it's 62.5 mils per hour. And he's going to have some bit more vomiting, I think. And I think he's actually going to get some diarrhea once they get this foreign body out. So I've estimated a litre over 24 hours, which is 40 mils per hour. So we add all of those up, and that's how I get my initial resuscitation rate, which is, pretty hefty. We're going to give 400, just over 400 mils an hour for 4 hours. But that's going to really massively improve this dog's hydration as well as it correct. We would have corrected any hypovolemia with our boluses. But we don't just hook him up and go, because we don't know if this is definitely the rate that he needs and how much. We'll be reassessing. I'll turn it down sooner if we need to. So just to show you roughly, if we just put him on what we call twice maintenance, it could take up to 40 hours to correct that deficit. And 4 times maintenance, which is kind of surgical rates, it still could take 13 hours. So it's something, just be mindful. Don't just say, we'll just guesstimate and to put him on twice maintenance. If they're really dehydrated, they actually do need reasonably aggressive rates initially. Lucky for Shadow, the surgeon's got his foreign body out and he got home to Dad. So winding up, understand what's missing, where is it coming from, your intravascular space, and you've got hypovolemia, or your extravascular space and it's interstitial. You're going to match the fluid to the deficit at the right type, the right rate, and the right endpoint. Protect that little fine glycocalyx, even though we've just, it's amazing. I'm so impressed as what it can do. You're going to resuscitate, rehydrate, figure out your maintenance, and then be ready to stop those fluids sooner than I think we just often leave them on fluids unnecessarily. Reassess, reassess, reassess. I guess that's all I can keep honing into you. All right.
So we are open for questions.
I had some very interesting questions taken in the break, and I just wanted to perhaps address them to the group, because there were some very good questions that I know you all would want to understand. So the first question that was posed to me was, when do we feed after intestinal surgery? The answer for this is as soon as the animal is awake. So in days gone by, we talked about starting feeding 24 hours or more after surgery. If these animals are going to dehiss, they're going to dehiss whether you feed them or not. And in fact, the studies show that their dehiscence rate is less when they're fed within the first 24 hours. And this is because the enterocytes receive all their nutrition from the gut itself. So if you want these animals to start their gut moving again as soon as possible, I feed them the night of surgery.
Excuse me, sir. So sometimes we have this delayed presentation where there is already onset of peritonitis. So when we open the abdomen, do you think adding an antibiotic to the lavage does help in any ways?
Yep. The answer is no, I don't place antibiotics directly into the abdominal cavity. I think that if you have good vascular supply to the tissues, then you will have delivery of those antibiotics if given intravenously. If you have necrotic tissue without a blood supply, that needs to come out anyway. And so there are many other components to injectable antibiotics. I think you're probably more likely to cause local irritation without the benefits of the antibacterial effect. So I just give them intravenously, and then I look at addressing the local environment through debridement and lavage.
And sometimes,
Excuse me, really sorry to interrupt. For all those who are leaving the hall, I want you to know that please be present on time tomorrow. We will start sharp at 9 a.m. as we are having our combined lectures tomorrow, and we do not want to get delayed. And thank you. You can continue.
so one more question. Sometimes we need to sacrifice whenever we want to anastomose. Duodenocolic ligament we have to cut and we have to excise that part. So during that thing, do you think we need to restore that natural thing what it is there? Do you think duodenopexy to the abdominal wall is something required or necessary?
Yeah, so the question being the duodenocolic ligament, and if we transect it, do we need to re-establish it? I haven't, and I don't know of complications associated without that. I think it's very hard to re-establish it because it's essentially a joining of one bit of peritoneum to another. I think it's very hard to re-establish it once you've cut it. So I don't try and reattach it because I think the risk is we could damage vascular supply. So in my opinion, there's no need to re-establish that.
Thank you.
Any other questions?
Okay, we have a microphone coming now.
In cases of neoplasia in intestines, how much amount of intestinal segment would you sacrifice?
Yes. So because we have normally a significant amount of small intestinal length, I will take 8 to 10 centimetres.
But that is for what amount, what kg of body weight of dog? What about a 2 kg, 3 kg body weight of dog?
Even in those small dogs, it generally is about 1 jejunal arcade. So, when we look at the branching trees, I sort of take one tree on either side. So generally, it's fairly similar between big and small dogs.
That's the landmark?
Yeah, so normally about 1 jejunal branch, on either side. Yeah.
Chris, this septic peritonitis with closed drain management, if it fails, have you done any open drain management?
Yeah, so open peritoneal drainage is something that's very labour intense. So this is where you only partially close the abdominal wall and you essentially place laparotomy sponges and absorb all that fluid. I think the risk here is introduction of new bacteria with open peritoneal drainage. If something fails, it's not the drainage generally, it's more associated with failure of the underlying repair. I guess the studies that have compared open and closed drainage show very little difference between them. They can all be quite appropriate and successful, but the morbidity associated with open peritoneal drainage, the care and the effort taken is significantly higher than closed drainage. So my approach generally is if the peritonitis is early and mild, and if we've controlled the underlying problem, it's acceptable to close that primarily without drainage. I think if you've got any doubt at all, you place a closed suction drain like a Jackson Pratt, and there's very few situations where I would do open abdominal drainage. So that would be extremely rare, because with the modern Jackson Pratt drains, they come in all designs that mean that you can get quite effective flow. But it's like any other wound. If the fluid keeps coming, something is going wrong. The body knows what to do. So that fluid should very rapidly reduce. Both in its nature, it should become more serious, and the volume should decrease. If it doesn't start doing that in the first couple of days, something's going wrong, and it may be you've got ongoing leakage. So again, think about what the body wants to do. It should clean up any wound, including abdominal wounds, or septic peritonitis, within a couple of days. And if not, you need to go back and check what's happening in the abdominal cavity.
Yeah, one case actually we did it like that, closed drain. It failed. Yeah. Inevitably, I had to open it. That's only one I've done in 40 years. Yeah. Open drain. Yeah. It worked.
And if you
I had no choice.
Yeah, but what is likely to have made the difference is the second surgery and the repair rather than, or was it just a block drain? Everything else was okay? It was just a block drain, or?
No, I use Jackson Pratt drain
Yeah.
only.
Yeah.
With the closed suction drain.
Yep.
Just lavaging every day, saline,
Yep.
with all that. First 3 to 5 days. Animal got better, discharged home. 7 days later, the owner calls me again. Oh, my dog is not eating, feverish. Then told them to come back.
Yes.
Temperature was high. I had no choice, basically. Just went in. There was a lot of fluid buildup there.
Yes.
This is despite being an intravenous antibiotics.
Yes.
So lavaged it, open drain,
Yep.
just leaving 1 centimeter apart the linea alba.
Yes.
So every few hours change of dressing.
Yep.
Finally,
Yeah, I mean, it follows the principles. It's
Yeah.
just a lot of work.
Yeah.
And you can place multiple Jackson Pratt drains too. So you can place one cranially and caudally if you think there's going to be a lot of fluid being produced.
I put 2 in this case.
Yeah, oh,
still,
that's
yeah.
unlucky. Yeah.
And also the gastric mucosa. Do you trim the gastric mucosa, submucosa before you close it?
No, not generally.
Okay.
No, because it's too voluminous. You'd be trimming forever, I think. Yeah. So because the layers are quite separate, I don't think you have to. Where in the intestine, when the layers are quite close, the mucosa bulges up over the edge, and that doesn't happen in the stomach.
Thank you. Thank you.
And I guess before we take this next question, I just wanted to say the techniques that I've shown you are very principles based. So if you've been doing it a different way and you're getting really good results, I would not recommend that you go and change things up, because as long as we are providing airtight, watertight seals in an atraumatic fashion, you can do things a number of different ways. This is not the only way to get intestinal incisions to heal. I guess over the years I've learned this is probably the most reliable and the safest ways to do that. But again, if you've been doing this for a long time with good results, I wouldn't change anything. This is a way, it's not the way. So keep that in mind. It's, you'll hear lots of different opinions. And again, everyone's hands work differently. So we follow the principles, not every fine detail. As long as you abide by the principles of surgery, I think you'll get a good result. Sorry.
You have discussed everything regarding the gastrointestinal emergencies, like this your obstruction, neoplasia, foreign body, GDB, like this. Every cases you have got the symptoms of vomiting and like this. So one cases we are dealing also, there's so many cases we are finding, there is no obstruction at all, only the radiographic picture of X-ray, there is an inflated intestine with a gas-filled intestine, and there is no fecal defecation, absence of feces in the colon, and everything is there, but the dog is not eating, totally dehydrated, and we have to go for exploratory surgery, whether there is any obstruction or right. It is not detected through X-ray or ultrasonography. Then we go for exploratory surgery, then we find all the intestinal lumen is very, very flaccid and loss of peristalsis. What is the management of these cases?
Is very flaccid.
Flaccid.
Yeah, no peristalsis.
Just like a paralytic ileus. It's
Yeah.
very common in Labradors.
Yeah, so certainly the way the body works, if there's inflammation in the abdominal cavity, is the guts stop moving. You get ileus. And so if there's leakage and a peritonitis, the body does a couple of different things because it doesn't want to spread any contamination. So with any sort of inflammatory condition, you tend to get ileus, so the guts stop moving. You can auscultate and listen for gut sounds and you hear none. The body wall stays rigid. And so, again, they don't want to move things around. Now, in these cases, it's common also post-operatively. So you do an enterotomy, you remove a foreign body, and then the guts become paralysed. So this can occur with medications. So I use opiates sparingly because even buprenorphine, but even methadone will slow the gut down. So I try and get them off the opiates quite soon after surgery. So I use local anaesthetic incisionally. We do a tap block. So this helps with pain. It helps me minimise the amount of opiates. We also look at using things like paracetamol because, again, this helps with visceral or gut pain, 10 to 15 milligrams per kilogram per Ros, 2 to 3 times a day. And so I try and minimise the amount of opiates. Feeding them will stop the ileus. So the best stimulation that you have to get the guts moving is to give them food. So we can look at either microenteral nutrition, you can syringe feed them a bit of food, and again, when that hits the gut, it triggers, again, cytokine release, which stimulates gut movement. So I want them eating. Sometimes I'll place a nasogastric tube, so then I can evacuate the fluid which often accumulates, because if they have ileus, they're not moving that fluid through. So often they have a big distended stomach, so a nasogastric tube can help you empty it.
But not responding to fluid also. There is a not responsive fluid also.
So then you would look at starting prokinetics, so things like metoclopramide as a bolus or CRI, as long as you know that there's no obstruction there. But essentially there's no magic trick to it. So you need to look at multifaceted approaches. So minimise the drugs that might lead to paralysis, identify obstruction or other underlying causes, and then you might try prokinetic drugs. Otherwise, time. These can be very frustrating. They can take days to recover, but you need to address multiple issues with the
What
ileus.
is the ultimate fate of these animals? It is curable or non-curable?
Yeah, it's very curable, but normally it might take 4 or 5 days. But it's hard work. These are frustrating cases. Yeah.
Thank you, sir.
No problem.
Do we have any other question? What about our backbenchers? By the way, there are no backbenchers in this field. We are surrounded by such brilliant minds. Can we have a huge round of applause for ourselves as well?
All right. Well, thank you very much. Tomorrow we're going to modify the talks a little. So we're going to talk about biopsies and exploratory laparotomies and urinary tract emergencies. And then Ellie and I are going to give collaborative sessions. So we're going to go through GDV and urinary tract emergencies from both a surgical and an ECC point of view. So we're going to do this all in the morning session. So the timings may be a little bit different, but be here at 9 and we're going to cover all of that through that morning session. So first of all, we're going through some basic principles, then we'll go through that collaborative approach. Because for all of you out there, you may not have a criticalist or a surgeon that you work with, you're both of them. So this way you'll get both our point of views on both the urogenital emergencies and also the GDV as a case example. All right, thank you.
Thank you, everyone. All the queries are solved or not? All right. And with that, we come towards the end of our day 2 of 23rd Vasava CE India and 16th FSAPI National Symposium, which is organized by Small Animal Clinicians Association Chandigarh Saca under the auspices of Federation of Small Animal Practitioners Association of India, FSAPI. It has been a day filled with insightful session, meaningful discussions, and a lot of learning. And I hope to see you all tomorrow on time, all fresh. We'll start sharp at 9 a.m. So please be here on time. Thank you. And at 7:30, we'll start with the snacks, and a cultural program has been organized for all of you. So go have fun, enjoy. See you all tomorrow. Thank you. Also, remember to collect your certificates from the registration desk. Thank you.